Like many developing nations, Vietnam has struggled to cope with the prevention and management of HIV and other sexually transmitted infections. Although HIV was late to arrive in the country, it has now been reported in all of its 64 provinces, with the estimated number of people living with HIV more than doubling in the past decade. The Vietnam HIV/AIDS STI Community Clinics Network Project, or HCCN, was launched to provide development assistance to the Vietnamese national healthcare system, with a focus on improving their HIV/AIDS and STI prevention capacities. Dr. Mike Renkart is the director of the Sexually Transmitted Infections and HIV Prevention and Control Division at the British Columbia Centre for Disease Control in Vancouver, Canada. He took the first steps towards initiating the project after meeting with the Vietnamese delegation attending the 11th International Conference on AIDS in Vancouver in 1996.
We talked with the Minister of Public Health, and he basically invited me to come to Vietnam and to help out in some way. I went over a couple of times and I met with various people, and I tried to find the right niche for my group to help out. Fortunately, the right niche was sexually transmitted disease clinics. So that was great because that's what we do here in Canada. So we have the expertise required and we have the experience for STD care.
During this initial exploratory process, it became apparent to Dr. Renkart that one of the issues in Vietnam was the method of STI management being employed.
A big thing that I noticed when I first went there was that Vietnam has a lot of healthcare workers, more doctors per capita than Canada, more hospitals per capita than Canada, so they had a very well-trained health workforce. The problem that I saw was that the government-sanctioned STD management system was based on syndromic management.
First developed for countries that have low resources and lack reliable diagnostic facilities, the syndromic approach entails treating patients for all possible infections that can be attributed to their symptoms.
They could be treated for up to 5 different diseases because there's not the potential to do an exam or to do any lab, or at least that's not part of the system. Our hypothesis was that syndromic management was inappropriate for Vietnam, that they should use etiologic management, which is the same management we use in Canada and North America.
Etiologic management is a standard method throughout the developed world. It is widely accepted as being superior to other methods of STI management because it provides accurate and targeted treatment based on test results.
Vietnam is quite capable of the higher level of STD management because they have many trained healthcare workers and they have many laboratories. So the etiologic approach to STDs is the key to this project.
It does, however, require highly trained medical personnel, diagnostic tests, and well-stocked laboratory facilities. And although hospitals in major urban centers in Vietnam already use the etiologic approach, the capacities throughout the rural areas had yet to be developed. A need existed to increase the capacity of the national healthcare system for employing etiologic STI management by building a network of connected clinics and referral laboratories in the Mekong provinces of southern Vietnam. The HCCN Project was born.
It's a project to prevent HIV by treating and preventing other sexually transmitted diseases, because there is this very close link between sexually transmitted diseases like gonorrhea and syphilis and HIV.
Studies have indicated that the presence of STI infections can increase the transmission of HIV by up to as much as tenfold.
The reason that sexually transmitted diseases and HIV are so closely linked is because people with sexually transmitted diseases transmit HIV to someone else more easily, and people with sexually transmitted diseases acquire HIV more easily. So if you control STDs, you can control HIV. Our project is to prevent and treat STDs in marginalized populations, especially sex workers, as a way of preventing HIV.
The question then became where precisely to implement the HCCN project. 4 provinces in southern Vietnam were selected based on the vulnerability of the population.
Kinh Giang, it's the province that's on the sea. There's lots of high-risk seafarers there, and there's tourists that come through. An Giang has the largest border with Cambodia, and many of the Vietnamese sex workers in Cambodia are from An Giang province. The huge metropolis of Ho Chi Minh City has lots of mobile populations, tourism, a lot of sex work and drug use. And lastly, Can Tha is the capital province of the Mekong Delta, so there's a lot of immigration in and out of Can Tha province.
The HCCN project chose to focus on targeting vulnerable or marginalized populations, primarily sex workers, intravenous drug users, migrant workers, seafarers, and the poor. However, this approach met with some difficulties.
I think focusing our efforts on a marginalized population was very new in Vietnam. These populations are not highly valued in many societies, but especially in Vietnam, where healthcare resources are very limited. They tend to be focused on people that are productive in society, and so sex workers, drug users usually don't get healthcare. And that's been our biggest challenge in Vietnam is stigma. The stigma associated with our client population has caused the most difficulty in the project.
The HCCN project set out to create a network of modern clinics at the community level while building capacity among Vietnamese healthcare workers, ensuring that those in the medical profession were equipped and well-trained to deliver care. In order to get things started, there needed to be a competent local team in place, and perhaps the most important component of all, strong relationships developed with local partners.
The head of the AIDS committee in Ho Chi Minh City helped us to make contact with the other three Mekong provinces, and we visited them together many times and tried to come to an understanding with the provincial health departments where the clinics might be, what the characteristics might be. And so we spent a couple of years actually looking at agreements and building relationships before we were able to start our first clinic.
Receiving its funding from the Canadian International Development Agency, the HCCN project consists of 6 implementing partners. In Canada, the British Columbia Centre for Disease Control, or BC-CDC, and in Vietnam, the Ministry of Planning and Investment, the provincial departments of health of An Giang, Kiên Giang, and Can Tha provinces, and in Ho Chi Minh City, the Committee for Population, Family, and Children.
For each of our provinces, we have a provincial management committee. These management committees are generally headed by the provincial health departments. However, they have representation from a wide variety of ministries and departments. Police always have to be there. Foreign Affairs is there, the Women's Union, the Youth Unions. So we have all of these different partners sitting around the table discussing the projects and where to go from here and what needs to be done or what the challenges are. And they do that on their own, and we meet with them once a year to go over the status of the project and try to chart a way forward to help them out.
In addition, the BC CDC established the HCCN Project Office in Ho Chi Minh City.
That office, composed strictly of Vietnamese, is our link to our clinic network and also the day-to-day support for the clinic network and the individual projects. They've developed a lot of expertise and a lot of good collaborative relationships that have enabled the project to be successful. Mr. Hai is the project manager. He's the overall leader for the project. He has worked in healthcare for many years and with donors before, and he's worked in several of the provinces that we work in. Working with him, we have a young physician, we have a capable administrator, we have a very experienced outreach coordinator, and a person specially trained to work in An Giang and in Ho Chi Minh City. Not only do we have a project office in Vietnam, but we have a project office here in Canada. Rob McDowell and Judith Law are 2 part-time project managers here. They provide liaison and expertise between the division and our trainers and the project office in Ho Chi Minh City. They do all of the administrative work and the finances for our funder, CEDA, and all of the reports that are so critical for the project.
Central to the objectives of the project was setting up the infrastructure necessary to develop the network of clinics. Funding is provided by the projects for all clinic renovations, laboratory and examination equipment, specimens transportation, as well as for consumables such as medicine, lab test kits, and supplies.
Bên cạnh cái việc xây dựng hệ thống các cái phòng khám thì bên phía nhà tài trợ SIDA cũng trang bị toàn bộ các cái trang thiết bị cho phòng khám, cho 9 phòng khám. Thì trong đó có đầy đủ những cái trang thiết bị sử dụng cho cái việc khám và điều trị các bệnh leo qua đường tình dục. Đặc biệt là các bệnh viện tỉnh mà có nối kết dự án cũng được trang bị mỗi nơi một cái kính hiển vi huỳnh quang rất là hiện đại.
Each clinic is attached to a local health station or center operated by the provincial departments of health. The partners in each province manage the selection of staff, clinic operations, and supervision, and are responsible for paying clinic staff salaries. At the height of the project, a total of 11 clinics were in operation, with additional mobile clinics established to service industrial sites outside of Ho Chi Minh City.
The initial goal was to create clinics that were networked, not individual clinics that were isolated, because in the Mekong Delta region of Vietnam, there's a lot of travel back and forth, movement in and out of different provinces. There aren't provincial borders in any real way, and the issues are the same. Some provinces have expertise in some areas and some in other areas, so we see it as one large area where they need to exchange their own experiences and lessons learned.
The main role of HCCN clinics is to enable screening and treatment to clients with both symptomatic and asymptomatic STIs. Services are confidential and free and include history taking, patient examination, laboratory testing, diagnosis, treatment and counseling for both patients and their partners. The clinics also contribute to prevention efforts by promoting safe sex, condom use, and improving STI monitoring and surveillance systems. With everything in place, the changeover from a syndromic to an etiologic approach was not without significant challenges.
We are doing laboratory tests on site in our clinics, whereas in Vietnam the standard was to do laboratory tests at hospital laboratories. And we were doing it in real time, so we were doing the history exam, test, make the diagnosis at one visit. And in Vietnam, that would oftentimes be extended over several visits. The use of etiologic management in a rural environment presents special issues around electricity, shipping specimens in time, transport media, maintenance of microscopes in the hot, humid weather. So there are special issues which we have overcome, but are unique to the rural setting.
Chúng tôi khi mà bắt đầu thực hiện một cái chương trình gì mang cái tính gọi là đưa một cái ý tưởng hoặc là một cái quan điểm điều trị mới tới phòng khám, thì người ta luôn có cái thái độ là có thể tôi không làm được, có thể cái điều đó quá hiện đại, quá cao siêu. Nhưng mà khi mà chúng tôi bắt đầu làm việc từ từ với những cái phương pháp mới thì họ quen dần và họ bắt đầu nhận ra là cái điều đó quan trọng, cái điều đó cần thiết, đặc biệt là trong cái lĩnh vực khám và điều trị bệnh lây truyền qua đường tình dục theo cái tìm nguyên nhân.
We have administrators, nurses, doctors, outreach workers, and lab people from BCCDC that go over to Vietnam for an initial 2-week training when we open a clinic.
Initial trainings and refresher courses for HCCN clinic staff are held twice per year. The initial training program is 10 days long and is conducted in advance of a clinic opening. There are usually about 10 or more trainees in each class, as multiple clinics are trained simultaneously. Training is divided into specific courses for each position and include administration, clinical, laboratory, and outreach management, as well as epidemiology, gender equality, and computer systems and information management. Refresher courses are done over 3 to 4 days, and once a year an experience sharing workshop is held. Furthermore, the BC CDC team of experts are available for remote technical support.
These projects and their staff, even the frontline staff, get together on a regular basis, at least once a year, to share experiences and to learn from each other. So we felt that would increase the amount of collaboration after we left.
To inform targeted clients about the clinical services offered, as well as to share HIV, STI prevention information, the The HCCN project employs strong outreach communications efforts in the project communities. HCCN has partnered with local mass organizations such as the women's and youth unions and the Red Cross to support a series of communication activities named Life Skills. The aim of the Life Skills campaign is behavior change.
Chúng ta tập trung vào cái truyền thông cung cấp kỹ năng sống cho thanh thiếu niên trong cộng đồng, bởi vì thanh thiếu niên là những người có nhóm nguy cơ cao trong lây nhiễm HIV/AIDS hiện nay ở Việt Nam. Sao thanh thiếu niên trong cộng đồng biết được những nguy cơ đó và tự thanh thiếu niên đó phòng tránh. Và một mặt nữa của vấn đề cái cung cấp kỹ năng sống là giúp cho thanh niên chọn được cái hướng đi và cái cách sống tốt cho mình và biết bảo vệ sức khỏe cho mình.
The HCCN project trains core groups of trainers in the life skills curriculum, focusing on condom use, harm reduction for drug use, and protection from human trafficking. Contemporary participatory communication methods are especially emphasized. The trainers then go on to lead subsequent life skills communication activities, putting their new skills and knowledge into practice. Such trainings and communications activities are held periodically depending on the request of the partnering mass organizations.
Cái hoạt động thứ hai trong cái truyền thông đó là mình cung cấp cho những nhóm đối tượng nguy cơ cao, ví dụ như thủy thủ, rồi vợ con của thủy thủ, những người công nhân lao động di cư và những cái người làm gái mại dâm hay là những người nghiện trích ma túy trong cộng đồng. Họ biết được cái dịch vụ cung cấp của dự án HCCN là điều trị các bệnh nhiễm khuẩn qua đường tình dục để họ tiếp cận và họ điều trị ngay từ ban đầu.
On the island of Phu Quoc, support has been provided for a series of outreach communication sessions targeting vulnerable and marginalized population groups. These sessions, run by local healthcare professionals from the Kiên Giang Department of Preventive Medicine, are often held in small cafes or meeting places and serve to share useful HIV, STI prevention information with participants in a comfortable and accepting atmosphere. Socially marginalized populations can be hesitant to access healthcare services due to fear of discrimination. In response to this issue, the project established a special group responsible to directly reach out to the project's target population. They are called peer educators.
Mục tiêu của giáo viên đẳng là tiếp cận những người hành nghề mại dâm nghèo cũng như những phụ nữ nghèo. Ngoài việc tiếp cận không thì họ sẽ giáo dục những phụ nữ này cũng như những người hành nghề mại dâm này về HIV/AIDS, các bệnh lây truyền qua đường tình dục, về sức khỏe sinh sản cũng như về việc giảm tác hại cho họ. Ngoài ra thì một điều đặc biệt là về việc cách sử dụng bao cao su. Đó là một phần rất là quan trọng của dự án để nhằm giảm cái khả năng lây nhiễm các bệnh lây truyền qua tình dục, từ đó thì làm giảm khả năng lây nhiễm HIV.
Often former sex workers and drug users themselves, peer educators are selected by the local project partners and undergo training with the visiting BC CDC trainers and HCCN staff. Peer educators are supervised by staff of the local health station where the clinic is located and receive strong support from the HCCN Project Office.
Bên cạnh đó thì chúng tôi cũng sẽ đào tạo về kỹ năng, đặc biệt là kỹ năng tham vấn, kỹ năng tiếp cận, kỹ năng truyền thông cũng như là kỹ năng giáo dục để họ có thể đem những cái kiến thức họ học được để có thể tuyên truyền lại cũng như nói chuyện lại với bạn bè, với lại những người mà họ cần tiếp cận. Đó là những người hành nghề mại dâm và những người sử dụng ma túy.
Over the life of the project, some 150 peer educators have passed through this training process. Record keeping shows that over 50% of the total first visit patients at HCCN clinics were referred directly by peer educators, demonstrating the usefulness of such an outreach mechanism.
Here in Canada, we hadn't been using peer educators, but based on our experience there, we actually set up a peer education project or an element within our street nurse program that's been very successful. So we've learned probably as much or more from the Vietnamese as they have from us.
The achievements to date of the limited project team and clinic staff are considerable. This project was able to reach and positively impact the lives of many. One of the surprising initial outcomes identified by project management has been the success of some of the more remote clinics. At the outset, it was expected that they would face difficulties in accessing supplies and resources due to their isolation. However, these clinics performed extremely well, a clear indication of the hard work by everyone involved.
Trong cái dự án này có hai cái điều mà gây ấn tượng nhất đối với tôi. Cái thứ nhất là cái sự nhiệt tình của phía đối tác để tiếp nhận cái phương pháp điều trị này. Ban đầu cũng nhiều cái khó khăn lắm, nhưng mà dần dần rồi qua những lớp tập huấn, rồi qua những cái nâng cao và quen dần với dự án thì họ làm tốt. Cái điều đó là một cái điều rất là ấn tượng. Cái ấn tượng thứ hai là thật tình mà nói đó, ban đầu cái ý thức của họ về một cái dự án phát triển rất là khó để cho họ hiểu như thế nào. Nhưng mà sau khi cùng với văn phòng dự án cùng làm kế hoạch, cùng chia sẻ với những cái kinh nghiệm làm việc trong những cái dự án quốc tế, thì họ có những cái ý thức mới và họ thấy rằng họ nắm được cái vai trò chủ động trong cái này.
The provinces at this stage, they love our clinics. That's my impression. They were reluctant at first because it was not the national model. It required them to put in a lot of staff and time. They had to be equal partners. They had to put in a lot of work for our project. Plus, we were dealing with sex workers and drug users who are an underground part of their society. So that took a while to get things started.
As the project's closure begins to come into view, the focus turns to sustainability.
Đối với chúng tôi, khi triển khai bất kỳ một cái dự án nào có sự tài trợ của các tổ chức quốc tế, thì mục tiêu của chúng tôi đặt ra ngay từ đầu, tức là sau khi mà dự án kết thúc thì phải phát huy được và tiếp tục những cái thành quả mà dự án mang lại. Thì dự án HCCN cũng vậy. Thì thí dụ như với 3 cái phòng khám mà đã được tổ chức trong quá trình thực hiện dự án, thì chúng tôi sẽ tiếp tục giữ nguyên và phát triển nó thêm. Đồng thời với những cái hoạt động mang tính chất truyền thông, thay đổi kỹ năng sống và thay đổi hành vi, và các cái hoạt động khác liên quan tới giảm thiểu tác hại, thì chúng tôi sẽ tiếp tục bằng cái nguồn kinh phí của tỉnh cũng như là những cái chương trình mục tiêu khác để phát huy cái hiệu quả của dự án.
Chúng tôi dự định thì cái thứ nhất là cái phòng khám tại Trung tâm Y tế Dự phòng huyện Thốt Nốt thì chúng tôi vẫn giữ nguyên. Còn cái phòng khám mà An Phú và phòng khám ở xã Vĩnh Trinh thì chúng tôi sẽ giao cho cái Trung tâm Y tế Dự phòng quận Ninh Kiều cũng như là quận Vĩnh Thạnh quản lý. Để mà làm tốt được điều này thì chúng tôi ngay bây giờ thì chúng tôi đã gửi cán bộ để đi tập huấn, để mà những cán bộ này sau đó sẽ tiếp nhận được những cái hoạt động của dự án sau khi mà dự án kết thúc.
Once they started to see the results, and once their staff started to say how much they liked working in our clinics, then the momentum started to build. And so all of the provinces now that we work with are committed to continuing the clinics after the project is over.
Khác với các những dự án khác thì dự án HCCN có điểm khác biệt, đó là thành lập một cái mô hình khám và điều trị các cái nhiễm khuẩn lây truyền qua đường tình dục theo phương pháp tìm nguyên nhân, với những cái trang thiết bị hiện đại và đặt ở tại tuyến y tế cơ sở. Do đó cái điểm này thì giúp cho các cái đối tượng của dự án được tiếp cận dễ dàng, và các cán bộ tham gia dự án cũng được nâng cao cái kỹ năng khám và điều trị.
One of the benefits is that the provinces, through our project, have learned to work together and to share lessons learned. And the provinces and the health departments have seen that they have the capacity to deliver really first-rate care. They don't have to do syndromic management in Vietnam. They can do etiologic management. They can deliver an STD clinic service equal to what we get here in Canada. They have the capacity to do that, and I think they see that. In one of the provinces, they've gone ahead on their own to set up a 4th clinic, and that's in the Kinzang province, specifically in Phu Quoc Island. So they've actually gone ahead with our model and set up another clinic, which is what we want to happen. It's really the essence of sustainability.
Dự án này thì tôi tin rằng là nó sẽ tạo được một cái cơ sở khi mà dự án kết thúc ở 2 điểm. Thứ nhất là dự án rất chú trọng cái đào tạo nhân lực. Cái nguồn nhân lực mà dự án đã đào tạo cho các cái trạm xá sẽ là cái nguồn có thể kéo dài trong 10-15 năm nữa. Họ với cái khả năng, với những kinh nghiệm đấy, họ có thể tiếp tục làm mà không cần có tài trợ nước ngoài. Điểm thứ hai là họ cũng tạo nên một cái cơ chế quản lý các cái bệnh lây truyền qua đường tình dục. Và cái cơ chế này thì chúng ta cũng không cần thiết phải bỏ nhiều tiền, cứ thế mà vận hành thôi.
I hope that they have also seen that marginalized populations are important to them, not just to the epidemic, but to their community. And I hope that the provinces have developed a liking for Canada and the fact that we've been over there trying to help out. When you look at the issues in global health, especially in the poorest countries, it's so easy to help. You know, in a few days or a few months, you can do a lot, and you can know that you really did make a difference.
Thank you.